Well, hello, everybody. Welcome to the Healthy Joints, Healthy Lifestyle Show. And today we're doing this rapid question and answer session with the lovely and brilliant Dr. Julia Buchfuhrer. Hey, Julia.
Hey, how's it going? How are you? Good to
Good.
be back.
Good to see you.
You
So we
too.
have for the last 1 week compiled questions from our Got Gout Facebook group. And so Dr. Buchfuhrer has been kind enough to come on the show so we can go back and forth. And you're going to hear from two rheumatologists, moi, Dr. Dada, in Seattle, and Dr. Buchfuhrer. So if you have gout and you want to see an expert in Seattle, you get Dr. Dada. And if you are in Los Angeles, you can see Dr. Julia Buchfuhrer. She's been on our show in the past, but basically she is the founder of JP Arthritis and Rheumatology Center in Los Angeles, and she brings over 7 years of experience to the medical field. So we are going to jump into this right now with questions that were asked on the Facebook group. So,
And I will say I love this Facebook group. I love your YouTube channel. I love all of it. And we got some pretty good questions coming in from this group, and this group is rapidly growing.
I love it. I love it.
Yeah.
So, the first question, Dr. Buchfuhrer, from our gout patient was my husband, and it was anonymous. So, this is anonymous participant 620.
All right.
Okay, anonymous participant. So, my husband has been diagnosed with gout. He takes allopurinol for life, but still has severe attacks that leave him bedridden for days. His uric acid is normal. What can we do to prevent these sudden flares, especially before traveling? What say you, Dr. Buchfuhrer?
There's a lot to dissect and break down in that question. So, I see this type of patient all the time. I've been on allopurinol for years. I'm still having gout attacks. And my response to that almost always is you are not on a high enough dose of allopurinol. But let's dissect out the part where she said his uric acid is normal, because as we know, gout comes from the uric acid being too high. The blood is too saturated, so we get those crystals in the joints, and those crystals are shaped like needles, and that's what causes the swelling, the pain, the attacks. Now the labs cutoff for normal is sometimes 8.2, 8.4. But as we know, as experts in gout, that uric acid needs to be less than 6, or you are at risk of having ongoing flare-ups. So check that normal uric acid. If it is not below 6, we need to up that allopurinol as long as the kidneys and other parts of the body can handle it. If allopurinol cannot be upped, there's other drugs we can use. So what I would say is this: if he's been on allopurinol for many, many years, I can almost guarantee he's not below 6. If he's still having attacks, ask your rheumatologist to increase that dose. And the last part of this question is, what do we do for vacations? I don't know about you, Dr. Dada, but that is my most feared thing. I don't want my gout patient to be on vacation in the Caribbean, wherever they are, and just be stuck in their hotel room, not enjoying, right? So what I typically do is I'm sending my patient with anti-inflammatories on their vacation, depending on their personal medical risk factors. I'm either giving something like naproxen, ibuprofen, colchicine, or even a steroid pack, depending on what works for them. So I would say talk to your doctor, figure out what you can take with you on vacation, and get that allopurinol higher.
Thank you, Dr. Buchfuhrer. I think in addition, I think if you, I agree with you that I always say, hey, have this in your back pocket so that you're not screaming my name in the Caribbean with curses. So I typically like to give my patients a steroid dose, but I agree with ibuprofen. I'm always concerned that people are going to try to self-medicate. So
Yeah.
I try to avoid encouraging anti-inflammatory medications because a lot of times there's some kidney damage because they've been
Yep.
doing that for a while. So I typically don't do that, but I totally agree with the steroids. The other thing I would like to mention is that your patients, your husband's uric acid was low, but my question is when? Was it low during an acute attack?
Good point.
That may not really give a full picture of what is uric acid typically is, because sometimes during an acute attack, the uric acid can be low. And so it looks like, oh, uric acid is low, can't be gout, or, or we can't do anything else. But it may be nice to check the uric acid, just like Dr. Buchfuhrer recommended. Checking the uric acid when the person is not having an attack may be
I
helpful.
I could not agree more with that. That is something that is often missed. Oh, uric acid looks good, but hey, it was drawn during an attack. Yeah, great point.
Okay,
Um,
your turn.
yes, so we have another question here from Jojo Villanueva. It says, "Hello, doc. I have gout on my left ankle, common spot, and it has been almost 2 months, always coming back. I'm taking prednisone 30 milligrams at the present. What can you advise? I'm 52 years old and 86 kilos. Thanks."
Oh, hey, Jojo. My niece's name is actually Jojo, so I absolutely love that name.
Oh,
But
nice.
back to business. So I am so sorry to hear that your experiences in this, Jojo. It sounds like you're kind of stuck in this cycle. My first thoughts is one, that we've actually confirmed that this is gout. There are other things that look like gout. I want to make sure that your doctor has thought about that. That's one. Two, although 30 milligrams may be a decent dose for some people, I think if you've been having the attack for 2 months, my best analogy is that this could be like a forest fire at this point. And maybe your doctor may need to be more aggressive. So, one, is it truly gout? If it is gout, then your doctor would now assess, well, maybe the 30 milligrams is inadequate. Maybe the gout attack is just so aggressive that your doctor may need to increase the prednisone. 30, I think, is an average decent dose, but sometimes I've had to treat people on 60. But we never really want to keep people on long-term steroids. We always want to kind of, hit hard with the high dose and then lower the prednisone once the patient is pain-free. Your doctor may also consider adding something like colchicine or maybe even doing an injection. And there are even more sophisticated medications like Ilaris if your doctor is really having a hard time, depending on where you are in the world. But those would be my recommendations to talk to your doctor is, yes, the prednisone is the right medicine for acute attacks, but it sounds like if he's confirmed gout, then one is definitely, is the dose right? Is there additional medications that can be added? And then there may be more sophisticated medications like Ilaris that may be available to you depending on where you are in the world. So, yes, Dr. Julia Buchfuhrer, what else do you think we can add to help Jojo?
Yeah, I mean, I think you hit all of the different options. If that patient's coming in my clinic and it's the same joint and it's the one joint, I'm sticking a needle in it. I'm injecting steroid right at the source, and that steroid's going to get locked in there and just calm down that joint for a little longer. But I also more and more frequently have been using that Ilaris. It's a wonder drug. So
Yeah,
in places where you have access to that and you have stubborn flare-ups, I think that's a great option as well.
yeah, yeah, yeah. Although it's uncomfortable to give a patient a shot, I think I've never had anybody who got a shot and got pain free. I wasn't happy after the fact. So it
Yeah.
sounds sometimes a little like, I got a shot this period. People actually feel just the relief. I've never had anybody come back and say, I wish you didn't do the shot.
Yeah, yeah, no, it's so true. And it wouldn't be something I would use if somebody's had a 3 or 5 day gout attack that I expect to go away. But if we're talking 2 months
Two
now,
months, yeah.
I'm probably sticking a needle in that.
Yeah, I think we need to move forward, right? Yeah, we
Yeah,
need to break that cycle, like you
yep,
said.
yep.
Okay. Okay, the next person is Penny Chambers Jordan. And it says, my doctor said to start allopurinol when I'm 100%. I'm going to say I'm 100% cured. Um, but I've heard that it can cause flares. Why would I take it? And what about cherry juice, Dr. Brookfer?
I love cherry juice, but it is not. It's an add-on. It is not the answer. So to speak, it's the cherry on top, right?
Yeah.
But no, this is a great question. So when I was in training, we always said do not start allopurinol when someone's in a flare-up because it could cause the flare-up to be worse. And that was the mantra for so many decades. But now what we're finding is, hey, start the drug when the patient's there. Let's get this thing going, and we can concomitantly treat the flare up. So, why would allopurinol, the drug that's treating the gout, cause a flare up? That's weird. If I'm trying to get my gout better, why would I take something that's going to make it worse? Well, I always say there's kind of two buckets with gout treatment. There's, let's treat the inflammation and the pain I have now, the gout attack, and then let's get rid of the gouty crystals out of the body so I don't have an attack in the future. And so allopurinol does the heavy lifting in the chronic. And so as the crystals are moving out of the joints into the blood and then out of the body, as they're moving, they can cause these mobilization flare-ups. So it's absolutely true that as we're curing that gout, we can cause more flare-ups, but we just add some sort of a steroid or perhaps an anti-inflammatory, whatever it is, to calm down the flare-up. We can do both at the same time and prevent flare-ups. Now, as far as cherry juice, I love this question because actually in the gout group, which I'm a part of, I see a lot people saying, hey, you have an attack, just drink a ton of cherry juice, drink a ton of cherry juice. But the cherry juice actually isn't the anti-inflammatory stop the attack. The cherry juice is, let's lower the uric acid. It's the long-term treatment. And it does it modestly. It's not gonna, for most people, get them there. So if you want to add to getting rid of the crystals out of your body, you could drink that cherry juice. But in the same way allopurinol could cause a flare-up, perhaps cherry juice could do the same. So it's not going to do anything for your flare-up right now. And that's something I've been seeing a lot in this group is, hey, if you have an attack, take it. But the cherry juice does not work for that bucket. Anything you would add to that?
No, I think you said it pretty clearly. Yeah, just to reiterate, I think that, the cherry juice thing is, yes, it works, but not for the pain. It helps, just like Dr. Buchfuhrer says, it's going to help you eventually lower the uric acid, but it's just not going to be able to work on its own. So if your doctor is okay with you taking cherry juice in addition to the medications like allopurinol, fine. If you're like, oh, my uric acid is 6.1, I want to get it to 6, I don't want to increase the dose of allopurinol, you can experiment with your doctor and say, hey, maybe cherry juice. But I haven't found that people can consistently take that cherry juice, right? Right?
Mm-hmm.
Like they would with medication. But yeah, I think I totally agree with you.
Yeah, in the studies where they did the cherry juice,
Yeah.
for one, some studies showed it didn't help. Some studies showed it did help. And by saying help, I mean lower that uric acid. It lowered it a little bit, usually by 10%.
Yeah.
So if your uric acid was a 10, it might have come down to a 9, let's say, still not below 6. And that was with drinking a lot of cherry juice every single day. And
Forever.
that's just not something that most people want to do, right? So
Yeah.
at the end of the day, I would say talk to your doctor. Let's get some
Yeah.
medication in you.
Yeah. I mean, we both love cherries, guys, but the question is, will it effectively get rid of your uric acid or get your uric acid less than 6? And unfortunately, the answer is no, it's not going to be effective by itself, but we love cherries.
Yes.
Okay.
All right. I think next one is mine to ask. So we have anonymous participant 24. Um, this patient started metformin, presumably for diabetes. They're eating better, but for some reason, their right ankle and elbow are bothering them. I guess they're saying they have a gout attack. Is it related to them starting the metformin and changing their diet habits?
Okay. Well, anonymous participant 24, thank you for asking this question. Um, although the ankle and elbow is not the most common sites for gout, gout can certainly happen there. Metformin, on the other hand, is not known to be a trigger for gout. It's a very good medication when your doctor is trying to control your blood sugars, and also if your doctor is concerned about diabetes. Diabetes, heart disease, and high uric acid and gout can all kind of live in the same person. So it may not necessarily be the metformin. It may be the fact that maybe you're pre-diabetic. The other things that go along with this is high blood pressure. Maybe the kidneys don't work that well. And so gout can be part of that family. And so you may be predisposed to gout, I'm assuming, because your doctor is putting you on metformin. But metformin specifically does not cause gout. So I would say if your ankle and elbow hurt, gout typically presents more with like, it's very tender to touch. You can have it in your elbow and your ankle. It's tender to, you don't even want the sheets on it. You don't want anybody even touching it or looking at it. And it comes in waves, like it comes very intense, like somebody smashed your elbow with a hammer, goes away, and then it can come back a month later with another smash of the hammer. And so that's how gout is kind of more acute, intense, and then typically calms down. So that was the typical story, the typical history you would have if that was gout. But there's certainly a lot of other things that can give you elbow and ankle pain. So one is, your doctor can check uric acid, your doctor can even get x-rays. You could have tendinitis in your elbow. You could have even something called pseudo gout, acts like gout, or you have calcium crystals, not uric acid crystals. So one, I don't think that metformin is associated with joint pain. That would be the first thing. Metformin can be used in people with diabetes who may be prone to gout. Ankle and elbow are usually not the first places that gout presents with. If you do have gout, it's typically that acute, intense presentation. But I would say let's have you see your doctor. I think unlikely that metformin is causing it. And yeah, a uric acid test may be helpful, but your doctor will want to make sure they rule out other things. Dr.
Follow-up question
Brookferrer.
for you.
Yeah. Oh.
Are you seeing a lot of your gout patients also having diabetes or prediabetes?
I think that's true. I think that that kind of runs in that same, high cardiovascular risk that we've also found that a lot of gout patients have. So having that, that high risk profile where people may be somewhat overweight, have some high blood pressure, have diabetes, which sometimes complicates the picture when we're trying to treat them with steroids because steroids can make your blood sugars high. So we're always kind of sometimes just walking that fine line. But yes, I've found that a number of my patients do have diabetes, but it's part of that metabolic syndrome that they're kind of all experiencing. What do you
Absolutely.
think?
Absolutely. I'm finding the same thing. It's we talk about metabolic syndrome with diabetes, obesity. I feel like we don't talk about it enough with gout, and I'm seeing that in most of my patients.
Yeah, yeah.
Yeah.
I mean, we've started to look at at gout as being a cardiovascular risk factor. And
Mhm.
so when I say that, it's kind of like, so cardiovascular risk factors means that, it's something that can potentially damage your heart, cause a heart attack and stuff like that. So when we think of risk factors, I think everybody knows cholesterol, right? Everybody knows smoking is bad for you. We're thinking gout is also in that same kind of phenomenon, that same kind of criteria. And so we really want to try to encourage people to get their gout treated.
Absolutely. Absolutely.
Okay. And so the next question is from Dr. Gary Chimes. Hi, Dr. Chimes. So his question is, when do you prefer synovial fluid analysis? So that's analyzing the fluid from the joint, over imaging or blood work. And what are we missing when we don't do it?
Thank you, Dr. Chimes. That is an excellent question. And since we have non-rheumatologists, non-physicians in the room, I'll kind of break down the question before I answer it. So when we talk about synovial fluid analysis, what that means is we stick a big needle into the joint, we suck out the fluid, and we send the fluid to go look at under a microscope. They're doing that in the lab. Typically, we're not doing it in our office, but then we get the results and we can say, hey, look, they found some gout crystals, or hey, look, there's a ton of inflammation and it looks like, yep, might be gout. And so that used to be the way that they said you have to get that every time. But what they found is, hey, if it looks like gout, it smells like gout, that uric acid is high, it's the normal joints. Why are we sticking a huge needle into an extremely painful joint and subjecting a patient to that when we do not have to? So in my clinic, I pretty much am almost never putting a needle in and getting that synovial fluid. If the patient comes in and they give me a story that's consistent with gout, first thing I'm doing is checking that uric acid. If it's elevated, that's enough for me if we have a very consistent story, especially if I see the flare up right in front of me, right? And then if something seems off, I'm uncertain, I may add x-rays. I may add, if I'm lucky enough to get a dual energy CT scan, which is this cool 3D image. And so you can see the bones, and then any gouty crystals will light up as bright green. You can't miss the stuff. Really, really cool technology. I really resort to aspiration or even biopsy of something that might look like a tophus as a last resort, and only if I'm really on the fence as to what this could be. So I'll give a famous example that I share very often. When we say that uric acid around 6.8 or between 6 and 7 is the average saturation point in the blood, meaning if you're above that, you build up crystals in the body. If you're below that, you will be removing crystals from the body or not making any. That's an average. If you look at the data, that's an average. So I had a patient once. He had what looked like gouty tophi all over his elbows, and he was sent to me for rheumatoid arthritis. He had tried every rheumatoid arthritis drug, nothing worked, and the story sounded just like gout, but his uric acid was 4.6. I was like, no way is this gout. I repeated it. I said, maybe it was during a flare-up like Dr. Dada had said. So I repeated it, 4.6 again. So I tried to get a dual energy CT, insurance wouldn't approve. So I went ahead and got this thing biopsied, and it was absolutely a gouty tophus. So that person's biology or chemistry, for some reason, had a lower saturation point for uric acid, to where those crystals crystallized at a much lower set point in that specific human body. So those are kind of the cases where I'm going for biopsy or aspiration or whatever it may be. But even when I was in training, they were still saying, hey, stick a needle in that painful joint, suck the fluid out. I just don't do it anymore. I don't know about you, Dr. Dada. What do you think?
I agree with you totally, Dr. Brookfer. Meanwhile, good catch with that patient with the low uric acid.
Yeah.
Yeah, I don't remember when last I was moved to put a needle in a joint. I think the technology has improved so much. We have that dual energy CT scan that can really help us identify lumps or bumps or masses. So that's amazing. I think in the past, if I kind of cast my bread all the way back, is when I suspected an infection and I just wasn't quite sure. It wasn't behaving like gout, right? Then I was like, you know what? I don't trust that this is just gout. Then I've aspirated. Most of the time, they've been knees and stuff,
Mhm.
or somebody who has another autoimmune disease and now has this acute, that I'm like, okay, well, your rheumatoid arthritis is under control. Why are we having this knee or this ankle? And
Absolutely.
then we've aspirated just to really kind of confirm. But I totally agree with you. In this day and age, I think we're rarely doing synovial fluid analysis unless we suspect something else, but not just, if you're 100% sure it's gout, then we're not aspirating just to confirm anymore. But we used to in the past, Dr.
Absolutely.
Chimes.
Absolutely. I think gout is far too common for us to be doing that.
Yeah, yeah, yeah,
No, but
yeah,
great question. Great
yeah.
question.
Thank you, Dr. Chimes.
All right, we have anonymous participant 390.
Yeah.
Question for you, Dr. Dada. Does allopurinol taken for life cause damage to the liver, kidney, or other parts of the body?
Okay. So there's a common myth. I think people are always afraid of allopurinol and the side effects. So typically, people who are on allopurinol for a long time, after, initially when they are being introduced to the medication, we run blood tests, and those blood tests really kind of help us really look at the health of the liver. Allopurinol rarely affects the kidneys. Allopurinol is excreted through the kidneys. So if your kidneys are not functioning well, then we need to kind of monitor and maybe adjust the dose. I think the bigger concern with allopurinol is that people may have this hypersensitive reaction where they get a skin rash, and that skin rash can be from mild to really, 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 really severe. And so we have genetic testings, HLA-B5801. We can check your genetic testing now and see if you are at increased risk. You can ask your doctor for the genetic test for allopurinol allergy sensitivity, and you can get that gene tested. So once you get tested, then your risk for developing the skin rash, which is I think the more common and the more concerning side effect if it happens, can be, and then your doctor can determine whether or not you're a right person candidate. But in terms of liver tests, we do blood tests initially as we adjust the dose every month, and then over time it becomes where we're checking it maybe once a quarter or even once every 5 or 6 months once you're stable. But we wouldn't want to just take allopurinol now and then see you back in a decade. We would still want to continue to monitor and make sure that, because your body is going through changes, your body is maturing. Sometimes you're on other medication, sometimes you're having too much wine. I'm not going to talk about that. But yeah, so I think the liver still needs to be monitored for as long as one is on allopurinol. Dr. Buchfuhrer, what do you think?
Yeah, one thing I say when patients say, wait, you want me on this my whole life? What is this drug? I say it has been FDA approved for gout since 1966. It was developed in 1956. It's been out for a long time, and it's one of our safest drugs, in my opinion, that we can use lifelong.
Yeah.
Absolutely.
Okay.
And I agree with everything else you said there.
We're in agreement.
That's right. It's almost like we know something.
I imagine that. Okay, next question is for you, Dr. Buchfuhrer. This is Mary Kay Macy. Hi, Mary Kay. So, I am new and still confused about diet, medications, and treatment.
All right, Mary Kay, I love this question. Thank you for bringing it up. And I think that's the right question. You get diagnosed with gout, and basically you're saying, bring it on, tell me everything. I love it. I love it. I love it. So, as we've discussed before, there's kind of two buckets to treatment. We have, I'm flaring up right now, stop the pain, stop the inflammation, stop the attack. And then there's the other bucket of treatment is long-term, get rid of the gouty crystals out of my body so I don't flare up again. So if you have no crystals in your body, you cannot flare up. So how does that look? If your uric acid is, let's say 8, 9, 10, whatever it is, we need to get it below 6. The saturation point for uric acid in most people's blood is between 6 and 7. Most books say 6.8. So we don't want to be anywhere close to that. We want it way below 6. If we're below the saturation point, the blood will start to pick up the crystals out of the body and then excrete it into the urine eventually. So we're getting rid of those crystals. So what does that look like in a typical patient? Now, first I want to say, go see your doctor, hopefully a rheumatologist. They'll look at all the meds you're on, your past medical history, your labs, everything, and they'll tell you what meds. But I'd say in a typical patient, what we're going to start is some sort of medication to control the inflammation. So that's typically steroids or colchicine or something of the sort. And that's for an attack or even to prevent an attack. But the most common drug used for getting the uric acid down and thus getting rid of the crystals from the body is allopurinol. We also have febuxostat, we have probenecid, and we have pegloticase, also known as Krystexxa. And one I forgot to mention for the inflammation is Ilaris, which we've talked about before, more advanced medication to prevent flare-ups when the others don't work. So, we have a lot of tools. You need to go to your hopefully rheumatologist and figure out what tools are best for your gout. And it may be starting that allopurinol, but you may have to up it 2, 3, 4 times before you're at a dose that gets your uric acid low enough. So that's the first part. The second part is, you said, what diet? So there is often talk, especially on the Got Gout group, about gouty diet. I am a fan of gouty diet, but I'm a fan of meds first. So gouty diet goes on top of meds just to kind of clean you up a little bit more. It's not going to fix you alone. So things we talked about earlier, cherry juice can help lower that uric acid. So in this bucket of getting rid of the crystals, right? Things that can cause flare-ups. So some patients will say, hey, every time I eat shellfish, I get a flare-up. So I say, hey, until those crystals are out, avoid those things, right? Triggers, very common triggers, fish, shellfish, alcohol, especially beer, hard alcohol, things like that. So if you have a known trigger, I want you to avoid that till we've done our job with the medication. Once the crystals are out of the body, you won't be able to flare up. You can have those things again. Now, what I always say is, you can have those things again from a gout standpoint, but don't go telling your cardiologist, your primary doc, that I said you could eat whatever you want. There's other reasons to eat a healthy diet, but from a gout standpoint, if you have no crystals left in your body, it doesn't matter what you eat, you can't flare up. Would you add anything to that, Dr. Data?
No, I think you were very thorough. And I think, she still wanted to hear about the diet. And I'm glad you added that on. And just for clarity, yes, it's important, but it's an addition too. Otherwise, when they put people in the studies, they were only able to lower when the studies were they on a very strict gout diet, right? You only could reduce it by 10%. And you're in a study, they're giving you what you're going to eat morning, afternoon, and night. And so therefore, if your uric acid is 10, reducing it by 10% gets you to 9.1. You're still far away from below 6. So I agree with everything you said. And yeah, so Mary Kay, I hope that's helpful. And yeah, we're here to help you. And I think one example is when I worked at the VA, and our vets used to go during the weekend to fish and crab. So they'll go crabbing. And then they'll wash it down with beer. And Monday morning was our gout clinic. Right. So that's it. They'll be
I
like,
love that.
Dada, well, I had to have some crab and some beer, just a little bit. But then my friend gave me another pint. I'm like, OMG.
You
Okay.
know,
But if we
I
can get
love
it under control. Go
Yeah,
ahead.
I love that story because at the end of the day, they're out, they're being active, they're not letting the gout stop them.
No,
And,
they're not.
you
They're
know,
like, nah, nothing's gonna stop me. I'll see that Dr. Dada on Monday.
that's great.
Okay, yeah. So we
Uh,
want to get that under control so you can go enjoy your crabbing, your clamming and stuff in moderation, and then you don't have to come see Dr. Dada on Monday. How about that?
Absolutely.
Okay.
All
So
right.
this question, I
I
think this
think
is,
it's our last one, right?
oh my
So,
goodness, yeah.
this one's
Okay.
from Melanie Crystal. And this is for you, Dr. Data. Can gout caused by chemotherapy go away?
Okay. Um, I would say the answer is yes. So why would gout be caused by chemotherapy? So chemotherapy, as you know, is a cancer medication, and those cancer medications are trying to kill cancerous cells. And some cancer cells, like leukemias, they have a lot of nuclei in them, and many of them. And so when those cells are broken down, they end up forming like these proteins, like uric acid eventually. And uric acid, when you have huge cancer cells, they get broken down. The rate at which they get broken down too, they call them like tumor lysis syndrome. They're breaking down so fast because they got smashed by chemo. So they're not living a normal life cycle. There are many of them and they're all being crushed by chemo. And that leads to high uric acid levels. And then these uric acid levels, as we know, precipitate in joints, which are nice and cold, which is what uric acid likes. And then that triggers gout. So the good news is this is a temporary situation, assuming that this chemo is killing the cells and leaving the good cells alive, and that once this process is done, that there shouldn't be this ongoing chronic forever episode where tumors have to keep getting crushed. Now, sometimes your oncologist, the chemo doctor, may say, hey, why don't I put you on some of these gout medicines? Because we know that because we have to really crush all these cancer cells, you may be prone to gout during this time. So some doctors may say, hey, maybe I'll put you on gout medicines while you are getting this chemo treatment. But there's some cancers that maybe the chemo is long term. And so maybe the gout medicine has to be long term just so that you can have a good quality of life. Because that's the whole point, is not to go from oncology to rheumatology, is, to deal with gout, is to have a good quality of life. So that's something I would say maybe worth talking to the oncologists about, because sometimes they're not really thinking about it too. And then you may not actually tell your oncologist. You may be like, oh, my oncologist only cares about cancer, but your oncologist does care about your quality of life. So a short answer is yes, it can go away and it can be mitigated or treated so that it's not impacting your life. Dr. Buchfuhrer, what say you?
Yeah, I mean, you hit every nail on every head yet again. I would say just to add, most common cancers that cause uric acid to be elevated would be leukemia, lymphoma, just because when the chemo hits it, they just, as you said, the cells explode, the purines go everywhere, they turn into uric acid. It's not nearly as common with other types of cancers, but your oncologist should be able to add something on to prevent gout and get rid of it. And that should be no problem. And if they so choose, they could send you to a rheumatologist if they're having difficulty doing that. So when in doubt, see a rheumatologist, I would absolutely say, because gout is not something that anyone has to live with.
I agree with you, Dr. Buchfuhrer. You are phenomenal. I always like chatting with you. We always have like different ways of explaining the same thing, and I love the way you explain them and kind of break them down into these tiny little nuggets. I always get smarter when I talk to you. So
Oh, I don't know about that. I think you have more years of experience than I do, but I
I
will say
love.
this. You started the Got Gout group. It's been growing like crazy. People have a lot of questions. They want to get better. I hope we can do another one of these, maybe live sometime for the
Yeah,
folks.
we
It'll
just
be
need to get
really
on the.
fun.
Yeah, it would. I think that would be kind of the next step. But we'll definitely do this again. I love the way you answer the questions and just kind of break them down into nuggets that, the people on the God Gout group can really understand. So, if you are in the Los Angeles area and you are looking for a rheumatologist, and with any autoimmune disease and gout, please reach out to Dr. Julia Buchfuhrer. She is at jbarthritis.com, and you can find her online. She also has a Facebook group, JB Arthritis and Rheumatology Center. So you can find her in Los Angeles, and I'm Dr. Dada at Overlake Arthritis in the greater Seattle area. So find us if you're looking for a treatment, or you or your loved ones with gout. So like this video, share it, subscribe to our channel, and Dr. Julia and I will be back soon and talk to answer more questions with gout. Thank you so much, everybody. Appreciate your time.
Thank you guys.
Okay, bye, everybody. Let's see.